Hello everyone, and welcome to today's webinar on the medical student and the self. My name is Catherine and I work for Doctors in Distress. We are an independent charity providing mental health support to all healthcare workers across the UK. We run programmes of peer support groups which run from 4 to 10 weeks and specialist-led webinars such as this one. Please note, as I mentioned, this is a recorded session, but you will be able to remain anonymous if you choose. Only the speakers will be seen and you are free to change your name in the chat box. Today's session on the medical student and the self will be led by Dr. Michael Harding, a retired GP, and his grandson Leo Datnow, who's a fourth-year medical student. There will be time at the end for questions, but please do feel free to pop any questions in the chat or the Q&A feature throughout the session, and we can come to them at the end. Just super quick before we begin, it would be really useful to know how you found out about this webinar. So I am just going to launch a really quick poll. If you are able to answer, then that would be great. So I am going to launch that now. This is my first time doing so fingers crossed it goes okay. But that has launched now. If you are able to just tell us how you found out about this webinar today, that would be great. And I'll just give you a minute or so to do that. Thank you. Fab, thank you. And now let's get on to the main event. I'm going to pass over to Michael and Leo to take the stage. Thank you both.
Well, thank you so much, Catherine, and welcome everyone. Thank you so much for coming. I'm very happy just to say a quick hello first, and then I'll pass over to Dr. Harding. I'm not going to call him Dr. Harding throughout the session. As Catherine mentioned, this is my grandfather, so I'll be calling him Gramps as I normally do. But just in case anyone didn't catch that and thinks that's a bit weird, it's because we're related. Yeah, I'm Leo. I'm a medical student over at Barts, which is in East London. I've been an ambassador for Doctors in Distress for about 18 months, which has been fantastic. One of the best things that we've done is do some work with a focus group. I think a couple of the members of that focus group are actually here, which is really lovely. We sort of talk about the main issues affecting medical students and their mental health from various different perspectives and cultural backgrounds and geographical perspectives too. But today we're going to be talking a little bit about vulnerability. We're going to be talking about the doctor-patient relationship, and we're also going to be talking about self-reflection and incorporating reflective practice into your own clinical experience as a medical student. But all of this is going forward as you're sort of breaking the barrier between graduating and becoming a doctor, and helping that and using that to help you become a more resilient doctor. And I'm in that position now, so I'm thinking about that a lot and reflecting on that a lot. And I'm hoping this will be quite conversational. I know there's a sort of Q&A feature that people are more than welcome to put things on, but I'm hoping with Gramps and I that this will be quite a sort of nice opportunity for us to bounce off each other rather than it being a sort of interview style or anything like that. But before I go on anymore, I'm going to pass over to Gramps, who's going to say a quick hello.
Hello to you all, and thank you very much for having me. As a retired GP, I have really enjoyed 50 years of single-handed practice, and chose to do that on a private basis because I wanted continuity, and I wanted to be able to have a practice where I knew who my patients were, they knew me, and we developed a very long-standing friendship. The position now is that I've had the opportunity and really welcomed the opportunity of discussing Leo's transit through pre-medical school, medical school, and so on, and fascinated by the differences that take place today and what are the challenges and what are the great benefits. So I thought that, having just given you that introduction, we'll embark on Leo leading us into the first topic.
Wonderful, thank you so much. That's a great introduction, thank you. So yeah, I just sort of wanted to start off by talking about something I've had a bit of a chance to reflect on from 3 years now of clinical medical student practice. And it's something that I feel quite strongly about. It's this sort of, I've seen amongst my peers and I felt in myself that when we enter the hospital, when we walk through the sliding doors, rotating doors, whatever it is, so much of our own internal conflict, of our own personal issues, of what we struggle with on our day-to-day, it just gets hung up at the door. And that's an automatic process. It's a subconscious process. Because as soon as we step into the hospital, we put ourselves into the shoes of competent clinicians. And I think the main problem with that is that actually when we're in our day-to-day and when we're practicing or learning as a medical student or as a doctor or as any healthcare practitioner, you don't even realize that it's there because you've left it at the door. And what happens is it stays there, it stagnates there, and you pick it up and you take it with you when you go home. And not only are you exhausted at that point when you go home, whether you're a medical student or anyone else, you are exhausted when you leave. And what happens is that then just gets taken on and bottled up and it stays there because you've used up your energy throughout the day, basically, bless you, playing the role and fitting the part of a impenetrable fortress of a clinician. And I think the problem with that is that then there's no energy left to reflect on that and to process that and work through that. And the problem is then over time, as that pressure builds, you start papering the cracks however you can, because it's, at least what I've seen and what I've felt, is it's a sort of never-ending struggle to desperately avoid those personal conflicts from creeping up and interfering with your practice. And I think that speaks massively to the culture that we nurture in the NHS of error, really dangerous error culture. I think it speaks to the culture of toxic communities within the NHS that I've seen and been a part of myself. And there needs to be a cultural change. There needs to be a reworking of how we view and deal with error. And there needs to be, and that needs to happen from the bottom up, so from medical students up. And as a doctor, there needs to be safer spaces for talking about error and for talking about personal issues and conflicts that actually do integrate into your practice, because we are human beings with very complex personalities and we have our own values and our own behaviors that we bring forward. And at the moment, what I see is that medical school standardizes students into competent knowledge, fountains of knowledge, and there is a real lack of integrating healthy behavioral practices of self-reflection and understanding humanity. And that's sort of the general gist of what I want to start off talking about. And I'm hoping a couple of you, even just hearing me say that, will have a bit of resonance with your own experience on placement and on the wards, and how much of a problem that will be, and that has been, and how much of a problem it will be continuing going forward as a medical student, and how it needs to change. So I'm interested, Grams, just to hear your thoughts on that.
If I may, and anybody wants to chip in, do so. But 60 years ago, as a medical student leaving preclinical and crossing the road onto the wards, I remember that day particularly well, because it was quite a burden. And you think to yourself, do I fit into this bracket? Will I realize a role as a healthcare professional? And I remember going onto the ward, and it was pretty old-fashioned. It was Albert Ward at St Mary's, which had 20 beds down one side of the room and 20 beds on the other side of the room. And we met in the middle, and the senior registrar, Bert Thompson, who was an absolutely marvelous teacher, but induced a certain degree of fear. And I remember the fear being realized when he tore a strip off me to say, Harding, what do you really think you're doing, turning up looking like this in a sweater? You must look more professional. Well, everybody's now wearing a sweater with their sleeves rolled up to their elbows. And so the image has changed, but the feelings, I don't think, have changed. When you are actually introduced to the patient sitting next to his bed, coughing his guts out, and Thompson says, you know, Davis, you really must stop smoking. To which Davis, who's really on his last leg, saying, well, it helps to bring it up in the morning, Governor. And, you know, those are those sorts of images which, in fact, you carry through. And they're many, many years ago that you carry them through to actually say, were they formulaic in terms of becoming a healthcare professional that you can actually extract from your patients what they need to tell you and what they wish to tell you, and that you are the recipient of that knowledge. So I feel very indebted to that process. And if I look back and say, how long did it take until I actually had the confidence to walk through the main door and say, I can make a contribution and I should make a contribution here. So I just thought I'd give you that little vignette.
That's really valid. I think that's really important. I think culture has changed a lot in the sense of exactly like you say, you know, the things you were reprimanded on have now become staples of infection control. When it comes to what you wear on placement and as a doctor. But I think the general sentiment of that really stands, which is that in the hierarchical nature that we work in, from the moments that you start, you feel undervalued because you feel looked down upon by registrars and even by people up above that, especially the junior doctor, let alone as a medical student. I wonder, Grant, what was the moment where you felt that transition, where you felt as though actually when you walked through those doors, you felt like you were making a valid contribution, where you were confident in the decisions you were making and you didn't feel that scrutinized? Because that's clearly what at least to me propagated that feeling of distress and of self-doubt.
So as a medical student, it never really realized the responsibility that I was going to take. And it was only when, in fact, you are holding the needle and just about to withdraw some blood that you begin to realize that you've been given some degree of responsibility. And then as a houseman, that's F1, isn't it? That you actually get the responsibility of clerking the patients and putting them at their ease and trying to guide them through the journey that they're going to go on. But you still haven't got total responsibility for the patient. And until that moment happens, you really are an apprentice. And I'm a great fan of apprenticeship, that you actually are there to be guided towards your future. And when did it happen that I was actually felt that I was 100% competent? Was when I had the responsibility, probably 2 or 3 years later, where in fact I recognized that people were going to listen to what I had to say and act on what I was going to say, not as an autocrat, but as a team member. Because before that, you know, as Leo says, I felt really belittled by the process, and particularly by the arrogant leaders who really often walked straight past and looked straight through us.
So, you know, was that change in the sense of, you know, there's clearly a change to you where it felt like as a doctor, the patient, you were able to foster that doctor-patient relationship where you actually felt as though the patient was putting you in a position of trust, and actually that fed back to enable you to feel confident in your own values and duties. Do you feel as though that was a change in your actual hierarchy and title and profession, or was that more of an introspective change in self-confidence? Did it come from the
I think it was introspective, in the sense that I could recognize that I had a role, and without that role, the machine wouldn't work. And so as one moved on from being a clerical officer and arranging the theatre schedules, that you actually were given the responsibility to say, this person has got cardiac failure, what are you going to do about it? And you had to search through your knowledge and then act upon it. It's 3 o'clock in the morning, the patient has come in from A&E, and you are there making decisions which can be life-changing. That really is a significant move, and had to be valued, you know, for the rest of one's career, is to say that you are entrusted with something very special. And when you had done that a few times, you reflected on it when in fact you were faced with a case that you did not know what to do with. That's the point where you feel able to say, I'm part of a team, I need to engage with somebody who's going to take me with them.
Totally. I think that is such a valid point, because it speaks so much about capability, I think, and also responsibility at different phases of your learning and training. And I want to just reflect on 2 points of that. The first of which is about understanding your role. I have come across a wide range of medical students, and I feel as though I've actually been a different medical student at various points in my learning career, and still continue to change and evolve. But the parts of that journey where I have felt not only the most competent, but the most confident in my own learning and position in the hospital is where I've taken such a big step back from my own responsibility in the hospital environment. I think it's so easy when you put on the scrubs, even as a medical student, and you walk into the hospital, you adapt into the role of a clinician. Because I think it's really easy to fall into a trap where you think medical school is the time for me to make mistakes. Medical school is the time for me to learn. Medical school is the time for me to get it wrong. Once I graduate and become a doctor, that indemnity, as it were, is removed. And I think that's a misconception. I think that's a mistake. Part of that, there's truth in part of that, and I think that comes from a cultural, generational culture of how like I said earlier, how we treat error. But the point I'm trying to make is, if as a medical student you can step back and go, I'm still a cog in this machine, I'm still a part of this machine, but this machine at the moment will still function without me. And I think if you can then realize that and go, my cog in here is part of the learning part of that machine rather than the part of the functioning part of that machine, it gives you that sense of and that feeling of, I'm allowed to make mistakes here, I'm allowed to get this wrong, and I'm allowed to learn as a result of it. If you step into the role of a clinician before you've got the knowledge to do that, you will put an immense amount of pressure on yourself. And I think that's when you start realizing, you start basically creating a self-fulfilling prophecy where you go, I don't know this, I need to know this, I need to put the pressure on so that by the point I'm a doctor, I'm not making these mistakes anymore. And that's simply not true. And exactly what you said, Gramps, about feeling like you're part of a team is the reason why, even as a doctor, when you're in those strange positions where you go, this is a diagnosis, I don't know, this is a management plan, I don't know, I think that's still the point where you go, as a qualified clinician, I still need to learn from this. And that's the point of being part of a team. That's the point of belonging in a team, is so that you can take a step back from that and go, you know what, I still don't know this, and I need to learn from people with more of a breadth of knowledge. That's really, really important. And you will continue to do that throughout your learning and throughout your learning as a qualified doctor. And I hope that can, and at least, that's been a point of reflection for me where I've been able on placement to basically take a step back and go, what is my role here? My role here is not to basically step into the really big shoes of a doctor when I haven't qualified and I don't have the knowledge yet. My role here is to learn so that when I'm a doctor, I still have the sensibility and the tools to learn. I think that's exactly what you're saying. That's what that change was, is realizing whilst I am qualified, I still have gaps in my knowledge, and I still need to draw through my knowledge and pick apart what I've learned, but also find what I don't know from my peers and from my colleagues and from the breadth of information available to me. And I think that's such an important part about your own capability, and such a misconception and cultural misnomer that we still have and still exists in our practice. And I really hope that hits home for some people who feel as though on placement they feel like they're underperforming, because that's not the point of your clinical practice at that point, and it's still not the point of when you become a doctor. You will still continue to learn. That's really what I've taken from that. But one of the other things you said, Gramps, was about the doctor-patient relationship within that, because actually expressing a little bit of humility. Leo,
just before we get on to that, I just want to say one about inadequacy of knowledge.
Yeah,
inadequacy of knowledge as a medical student is why you're a medical student and you're still learning. And there's plenty of leeway to say, well, you better go back to the books and to the screen and find out what all that was about. However, once you're in the position that you're out on your own, and you think you are expected to understand what leishmaniasis is off the top of your head, and you don't, and you feel inadequate, and you have to not cover it up, but admit that you don't know at that particular point. I think admission of ignorance or lack of knowledge is terribly important. And so it isn't embarrassing. It shouldn't be embarrassing. For quite some time, it was embarrassing to me because I always thought everybody else knew exactly what leishmaniasis was. But I realized later on that they too had to go and refer back to the authority. So there is a change in one's confidence in terms of being able to portray an image of, I can sort this out with you.
Totally wrong. Needing to figure it out on your own. I completely agree. Yeah. But I think that remains throughout all of your training. You're always going to be in a group of people. Someone, you know, a clinician asks a question and someone's just looked over it and they whistle it off. And it's so easy to basically play that off as if you're a breadth of knowledge and you can just recall that fact so easily. But you don't know what people are, first of all, going through, but also what they've gone through clinically already in their experience. Everyone's experience is varied. People remember things for different reasons. And you are all at the same stage, depending on what year you're in. You are let into that year because you have the correct sensibility and tools to learn the content going forward in that year. It's so important as a result of that to stay in your lane and recognize your own capacity to learn. Everyone else is learning at the same rate as you, but some people learn things first and more than others. And that's totally a normal part of the experience. And it's a really important thing to reflect on. I do want to move on slightly to the doctor-patient relationship, because you raised such a valid point about actually embracing those gaps in your knowledge and that lack of knowledge as actually that's not something that breaks down the doctor-patient relationship, but rather something that builds that up. And I just wondered what your thoughts were on that.
Sorry, I didn't quite follow that. Thoughts on what?
So you mentioned a good point about how actually acknowledging the humility of not having a gap in your knowledge and not understanding something actually builds more trust with a patient in the doctor-patient relationship, because the patient can view you more as a human being. But I think it's quite easy to think that having a lack of knowledge, even in the intimate confines of a doctor-patient relationship, that could burn the bridges and decrease that trust. And I wonder what you think of that from the various hundreds of patients that you've had the pleasure of building that relationship with throughout your career.
It varies from patient to patient, and one judges on the basis of the clinical meeting. But it took a long time before I was able to share, I don't know the problem, but I can sort it out. And that really boosted the trust. And sometimes we had the time to be able to say, let's look this up together. And within a moment or two, I could really see what this was all about. They could understand because we went through it together and we worked that through. And that made for a much more confident view, because some of the cases that you're going to be confronted with each day are going to be difficult to unfathom. And they may need a more competent or specialist approach, or a colleague who just does cardiac failure as opposed to coronary artery disease. And I think that, you know, we are much more fortunate today, because I think the patients not only know more, but are less humiliated by the arrogance of our colleagues, and will be able to say, well, you know, come on, doctor, there must be another answer to that, or this is what I think it is. And the classic situation where the patient comes in and you say to them, well, Mrs. Jones, what's wrong with you? And she says, well, doctor, that's not my business. You know what's wrong with me. And you haven't even begun to take any clues. So there are, you know, changes depending on what the patient is like and what they are expecting. And sometimes they play games, and sometimes they're aggressive, and sometimes they're dismissive. It all depends on the day, on their approach.
Totally, and I agree. And you know, there's no one size fits all approach to addressing a doctor-patient relationship. That's basically the first thing you learn in week one, is that everyone will treat you differently and approach the consultation differently. It's absolutely true. I think, though, it is what you said earlier about actually having a collaborative approach in the sense of not only in terms of management, but actually in terms of investigation and diagnosis is really valid as well, because that's not something that we see a lot. When we go on ward rounds in hospital environments, we sort of sit there. The consultant who leads it, or the registrar that leads it, will say, okay, so how have things progressed in the last day? And the patient will say, well, this is happening now, and this is getting better. And then they will say, okay, well, it sounds like you've got this, let's do this. And in a clinical environment, in an outpatient department, rather than necessarily in a hospital department, it can work quite similarly. It's still relatively paternalistic in the sense of someone will come in and say, I've got this, there's 10 minutes. The healthcare professional will say, have you got this? Is this happening? Tell me more about this. What's your past medical history? And they will gather all those clues and basically use that pattern recognition to form a diagnosis. So you very rarely see a clinician going, you know what, I'm actually not sure about this. Let's look up some of these things together. And in my, I've never seen that. I've never seen that before. And I think for a lot of clinicians, that's the moment where they probably step out of the room. They would go, I need to speak to my higher, I need to speak to my basically superior, my senior, to work this out. And I wonder if what you're saying is actually really valid. If you can basically investigate some of those things, either digitally or through the knowledge that you have, or basically voice things and work things out with the patient, if that actually does build rapport. Do you think that it does do that?
It definitely does. And I have felt more confident about saying I do not know ever since I was able to join up with other people who were able to advise. So access to somebody who knows about cardiac failure, either to advise in the interim or to accept a referral, or that in fact, I find that in any particular speciality, let's say we're talking about urology, and they meet together on a weekly basis for an MDT, they have an opportunity of sharing their difficult cases, which may be, 10 days since they saw them, but they still carry around that doubt about the diagnosis. And the thing is that we are acting in a profession where we actually know that we're not always as adequate as we are portrayed or as we think we are. And that's why this is really such a privilege to be working with others, so that you can actually share your limitations, or from time to time, publish your newfound experience for the benefit of others. That's, I think, one of the great things about the confidence that one has in this profession.
Really, really important point. Absolutely. It's an acknowledgement of the unknown. But medical school specific, and I really hope people know that medical schools themselves confess to this, that medical school is a standardization process to enable everyone to think in the safest way to have enough knowledge to be a junior doctor. But the way that, and that sounds at face value like a good thing. It sounds like, right, you've got the sensibility and the tools that you need to be as safe as possible. And it's great. That's exactly what medical school should be. But the way that that is delivered and the way that you are trained in order to think like that is you are just basically presented with a breadth of knowledge of hundreds to thousands of different conditions in your clinical years and an expectation that you will act as safely as possible. And the problem with that expectation of safety is that it is believed to be a prerequisite. And I think it's really easy then to conflate that with what I said earlier about basically losing sight of the fact that you will continue to develop those behaviors and those skills as you go through. And like I mentioned earlier, and like you're saying as well, it actually benefits the doctor-patient relationship if you can sit back and go, you know what, I'm actually not going to diagnose this or manage this if I don't know something. That would be unsafe. The thing that actually builds the rapport, builds the trust, and enables some shared decision-making between doctor and patient is if you can actually use that humility and vulnerability that we've both been discussing earlier to go, right, well, this is not something that I've come across before. This is not something I understand. I'm either going to speak to a team member or let's work it out together. It could be this, it could be this. We live in a society and we're trained to behave in a way where we're so definitive. We give an answer, we give a treatment, we give a prognosis, and then we follow up. Whereas actually, if we can explore that with the patient, even if we make mistakes throughout that process, that's really, really important. So, that's given at least me a lot of space to reflect on that, actually, because I'd never really realized before that clinicians and actually might admit to the fact that they just do not know something in a consultation. I've always seen people basically make the best educated guess on their differential list and manage as that, which could potentially be unsafe and could build distrust if you basically push forward with that arrogance all the way through. If you have any other comments to make on that specifically, Gramps, I'd love you to say that now. If not, I wonder if now would be a good time just to sort of open the floor up to a couple of questions before we move on to our final topic. What do you think?
See if there are any comments about what you had said, or
Mm.
even
I missed
If
that.
anyone
Yeah.
has any questions, please feel free to pop them on the chat, or if you'd like to come on the mic and speak, you can use the raise hands feature and we can bring you on. I can see we've had a comment from a participant, and they said, I agree with this massively. On the patient side, I've dealt with misdiagnosis from GPs because they didn't want to just say they don't know.
I mean, it's bewildering, and no other profession necessarily do you feel that massive expectation to go, this is what it is, we've got such limited time, I'm going to manage it as this. I mean, it's potentially dangerous. It's so, I mean, I wonder how can we relate this to medical training, because actually the sort of cushion of being a medical student and having basically the cushion of going, I don't know, as a medical student is relatively common. When you're on the ward round, when someone asks you, yeah, what's the management of leishmaniasis, you say I don't know because you don't know. But when you qualify, it's so easy then to basically try and fill in the gaps and confabulate that. And I wonder if, as medical students, we can form a more of a culture of actually going, I don't know, and I'll learn this, and enabling that to basically break the boundary of medical student to doctor, and keeping that going is really important, because it clearly sounds like, from a patient perspective, that actually builds trust and rapport. What do you think, Graham?
I think what you say is very good, but it does evoke a number of different feelings I had as a medical student.
Yeah, I'm sure it does.
I felt inadequate.
Mm-hmm.
I felt in awe of my teachers. I didn't expect them to say, I don't know. And I don't think they would say, I don't know, because they're standing on a pedestal saying, I do know. And that's why they're where they are. And we as medical students were where we were. But it only takes a little while longer to recognize the humanity in each of us, that we can actually utilize our thirst for more knowledge and more education and collective sharing. And you and I talked about what was it that made such a difference to my confidence. I never hesitate to present the joy I had in group therapy as a member of a Barlint group, which is, I think, probably known to most people today, which is a support group for general practitioners led by a psychoanalytical psychotherapist, for example, who, when they bring the issues that have troubled them most recently by presenting cases and opening them up to their peers, to actually recognize that they too would be feeling that way, or they would come up with a suggestion about how to deal with it. So one's peers, as opposed to one's teachers, can be a very, very useful learning and sharing experience.
Absolutely right. But I think it's really undervalued and underutilized. I think because of the sort of impenetrable faultless analogy I made earlier, because of the sort of expectations we put on ourselves to be as competent as possible as medical students, the last thing we want to do is create vulnerability for ourselves in front of other students. I mean, the feeling, at least that I've had, which happens all the time, of being asked a question in a clinical environment by a teacher who, exactly like you say, is really superior, and then basically either trying to sort of make something up that sounds about right and getting it wrong, or saying, I don't know, it feels deeply humiliating, because you've basically created a crack in that facade that you've created, that you are competent, that you are knowledgeable, and that you will be knowledgeable when your job is on the line, as the misconception goes. So can you first tell us a little bit about what Barlint groups are? Because I'd love to talk a bit more about, first of all, what they are and how they function, but also how we can actually create those spaces amongst medical students to discuss. Because I think that the idea of being able to create that vulnerability amongst peers will make people into much more resilient and resourceful doctors. So I'd love to hear first just a bit about what is a Barlint group? Dr.
Michael Barlint was a psychoanalytical psychotherapist at the Tavistock Clinic. And on a monthly basis, he would collect 12 GPs to meet with each other and discuss their difficulties. So, for example, if in fact they had, it needn't necessarily be a clinical problem, it could be, but it could also be a management problem where in fact the doctor felt either that the patient was making advances to him and he didn't know how to place himself, or that he had embarrassingly made a mistake and he couldn't confess about it, all sorts of things. And even to this day, even after I've retired, I'm still a member of a group. We met this week and we talked about the difficulties about holding on to confidentiality for patients who wanted to retain the secret of their, let's say, the origin of the father of their child, because they were doing IVF and they hadn't responded, they hadn't told the child about it. There were all sorts of things where people were able to just share each other's experiences. I think the peer engagement is very much better than taking this to, let's say, a moral judgment or something like that. So I've done that for 25 years or more. And it was absolutely vital in terms of knowing where to take my problems. We all have problems. And I think, in fact, it's a reflection of one's emotional strength, one's professional strength, that we can, in a safe environment, talk and find out that actually others have got exactly the same problem. And whether one's in a practice of 10 doctors or single-handed, or in, let's say, a team of general medicine in the hospital, I think everybody can benefit from the experience of their peers. And even if, in fact, you're looking at the difficulties of being an engineer on Formula One motor racing, I think everybody needs to speak to each other. They don't necessarily want to, because they think they are actually, to begin with, admitting failure or admitting incompetence. And it's only in the safety of the group that, in fact, everybody is coming from the same position and there's sympathy and understanding.
Were you surprised initially when the Barling Group started 25 years ago and throughout how easy it felt to basically be vulnerable and to promote the mistakes or errors or ideas of incompetency that come forward in that group? Or did it actually feel really, really challenging?
Our group had been going now for many, many years. It was started by two friends, but more and more people came in, and it made no difference about the type of practice or their particular speciality. The important thing was that they all had a similar reason for being there, and it's very uplifting and reassuring to find out that you can share this with others. And we brought in more people, and they could be varied, whether they were, but they were mostly in the field of general medicine and general practice. Some with an interest in psychiatry, and some with a particular interest in psychotherapy in their own practice. But we're all coming from the position of wanting to share, and that's really the basis of it all. I commend anybody who might know about that. There's a book that Barling wrote many, many years ago called The Doctor, His Patient and His Diagnosis. Isn't that right, Leo? By Michael.
Actually.
And it really is very easy reading and fascinating to recognize, what these, the GP from Fulham had actually come along and described the case and what was said in the group about that. So that the presentation lasts about 2 or 3 minutes, and then the discussion from most around the room who would actually contribute very, very usefully.
I think. Go on.
No, I'm done.
Well, I was just going to say, I think the word reassurance is just really, really resonated with me when you said that, because I wondered initially, whether that's 25 years ago, whether that's today, if initially when all these clinicians come together and there's a structure to the group and there's a sort of bit of a pressure to put forward error if actually that was a really difficult thing to do, or if once something came, there was a sort of snowballing effect, and if actually there was so much reassurance just to hear that peers around you are also either struggling with personal issues, are struggling with their own ideas about competency, are struggling with their own ideas in a medical student perspective about exams or study. And it's really reassuring to me to hear how it clearly felt like a collective sigh of relief when people could bring those ideas forward. And I wonder if, I mean, I'm certain that I'm just thinking about my own sort of perspective and having spoken about these things amongst my peers. It doesn't need to be in a formal group therapy setting or even in a Barnet setting. It's fantastic that those structures exist for clinicians, not for medical students, but I think people will be really surprised, and I've been surprised myself that actually when I bring up these ideas of vulnerability to other students, in my head I've created this narrative that people will be like, no, I don't necessarily feel like that, and I'd be more alienated. But actually the response you get from people is an outpouring of recognition and resonance. And for people that are sitting there and thinking, I'm really struggling either with something academic, I'm really struggling with something personal, it's interfering with my own ideas about competence, it's interfering with my ideas about my practice and my learning, I think you'd be so surprised about how many of your other peers that would resonate with. And it's really interesting, when I've brought that up to doctors, to practicing clinicians, I've actually found something different. I've found I'm either met with a bit of a platitude, or I'm met with a little bit of like, even dismissal, because I think these doctors have actually spent their time in medical school creating and propagating this fortress analogy. And when they're met with a medical student, they probably see a bit of themselves in at the phase that I was in, they shut that down. And I think that's to basically create their own and support their own idea of competency as a doctor. But interestingly, medical students, whilst they may be sort of formulating those ideas, they're not cemented until you're basically your job is on the line and you're forced to basically fulfill the prophecy you've created to be competent. So amongst peers, I think you'd be really, really surprised with people who are sitting there and thinking, I wish I could speak to this amongst my peers, how many other people would resonate with that? And not only does having that discussion normalize the behavior, but it means as a doctor, you can keep recognizing that in students and amongst your peers yourself. And I think that's so, so, so important. We have had a question in the chat and I haven't had a chance to read it yet. Yes, yes, absolutely.
Is that a Barnet group does need to be structured, not very strongly structured, but we've always had in our group and in most others, somebody who acts as a convener, who's actually trained to say, right, folks, has anybody got a case? And then when the case is presented, if there's a moment's silence or two, the convener will say, now, come on, Dick, surely you've got a comment about this. And so that we need this as a group therapy. And it is actually much more, people adhere to the formality of it by having somebody who will blow the whistle if in fact it isn't quite right, and will also say, how did you feel about this? Because so much of this is about the feelings that one has in terms of the cases that are presented.
Yeah, I think it's important that there is structure for those specific formal sessions, but I think the point I'm trying to make is that actually I wonder if that structure exists and there's a need for that facilitation because these doctors have spent years, careers, lifetimes creating this prophecy that they need to be as impenetrable as possible and as competent as possible. So actually having someone to facilitate the idea of presenting a case where you have made an error or you can actually admit defeat is much more difficult. I don't know if that also needs to then be repeated amongst medical students. I'm sure that the sessions would be more fortuitous. People would bring more to the table if there was someone there going, look, I've been in this position, these are the mistakes I've made, and create a little bit of, shared experience. But I think the really important point I'm trying to make here is that while you're a medical student and while you have that cushion of being able to make mistakes, it's so important to recognize, whilst no one speaks about it, everyone feels this sense of inadequacy and incompetence. And I think if you're able to voice that, even in an unstructured format amongst your peers, either in the clinical environment or out of it in an unstructured way, you build the tools and you build the arsenal to basically be able to take that forward as a doctor, whether that's in a structured session or not. I think that's the main point I'm trying to make about the differentiation between structured and non-structured sessions to be able to share vulnerability.
Can you imagine looking at a medical student who's on a ward round and recognizes that, in fact, the clinician in charge has got it all wrong, and wrong in a major way, and the medical student wants to blow the whistle? Feels very inadequate, and in a situation that they wouldn't do so. Taking it to a group, it doesn't necessarily have to be the formal Barlib group, but they do need to know that their voice should be heard in an area, because to hold on to bad news is very destructive, and it demeans, and it also reduces one's confidence and respect for the work that you're doing.
Totally agree with that. Absolutely agree with that. And I've been in positions myself and heard amongst peers for myself. So I did a year intercalation last year in emergency medicine, where decisions need to be made in such a high acuity setting that mistakes do happen. And there are a couple of moments where I saw some errors. In particular, there was a patient I went to go and see in Deptford, which is in South London, who had been in a riding accident. They'd fallen off their horse and had a head injury. And they got up, they acted normally, but about 4 hours later, they started behaving strangely and then collapsed. It's probably an extradural hemorrhage, but that's what we thought when we went there. Anywho, when we intubated the patient, I noticed she'd started vomiting, which is really, really dangerous. And intubation is a tube that goes into the airway, and it's to enable the patient to breathe because they're not breathing themselves. But if they start vomiting, they will block that tube. And I remember in that moment having such a feeling of internal conflict of basically the clinician at the moment is telling everyone about how we're going to extricate this patient and take them to hospital. If I were to say something now, I will block that flow, I will take the clinician out of the zone, and I will interrupt every single one of those people from doing the important job that they're doing, because everyone's compartmentalized in that team. But as a medical student, I still voiced that. And that was really important. It potentially saved that person's life because we were able to just put a little bit of suction in and then continue straight away. And that's one example of a much bigger picture where I think a lot of medical students, because of that hierarchy we mentioned at the start of the session, feel completely inadequate, and totally it's not their responsibility to voice those issues. But if we can change that culture, that error culture, and that culture of vulnerability, to basically be able to recognise that amongst doctors and amongst peers, and medical students have that confidence to voice that in those moments, that would make such a difference. And like you've totally said, sitting on that error and thinking, why didn't I say something, makes you feel like you've contributed to that error. So I hope people know that even as a medical student, you are well within your rights to basically bring up error and bring up, because everyone makes errors. That's sort of the main point I've been making throughout this whole session. So being able to voice that, identify that, and try to rectify that within your own capacity is really, really important. I think that's exactly what you're saying as well, Gramps, isn't it?
Are there any points that people might want to raise?
I'd just like to have a second to read this question because it looks really interesting and I've only skim read it. So I'm going to read it out loud if that's okay. So this is from Emily, who says, how can medical schools better teach the vast amount of knowledge and skills required to become a safe junior doctor by providing space and focus for the individual first? It seems sensible to look at where someone is starting from and how they learn and what their grounding for learning is in order to effectively guide them into absorbing and learning the required information the best way for them. Personality types, learning types, and assessment are used commonly in the corporate world, a lot more from experience, and I believe this would be so helpful for medics early in their training. I'd love to hear if this is something that is in medical school these days. Such an interesting question, and in answer to it, in a very brief answer, absolutely not. It's not something that is incorporated in medical school and definitely should be. There is a blanket deliverance of clinical content that has been in medical education for years and years and years, and that is lecture-based content, case-based content, and team-based learning. And I haven't done a lot of research into medical education, so I'm sure there are various pioneering ways that's changing. But you're totally right. Not only do people have different personality types and different learning styles, but people also have completely different learning abilities. So people with learning difficulties, people with that process information more slowly, people that are more visual learners, people that learn more from experience, especially in the preclinical years, just aren't accounted for. And it's these people that really fall behind. And then again, that propagates this whole cycle of thinking, I'm not good enough, all my peers are better than me, and no one is expressing that vulnerability, no one is expressing that error and that need for a slower pace of learning. So definitely that needs to be integrated more. The difficulty is trying to do that for everyone. What at least I know my medical school does is identify people who are performing more slowly and who get lower results in exams. They're then picked up by the academic support team, and then they will be helped and supported. But I've had a bit of experience with those teams, and even then it feels a bit like a blanket policy sometimes. I've met with an academic advisor who has basically gone, well, have you tried flashcards, or have you tried writing this into notes? Have you tried doing past paper practice? It feels a little bit like they're following a script and following a set of checkboxes. And what actually needs to happen is take a much more holistic approach to learning, which is that some people basically need to learn from error, some people need to learn from experience. And if you can facilitate that, then people will learn a lot better. But it's really difficult. I don't know enough about medical education, really, to be able to expand on that anymore, to see how things are changing around the country. I mean, I know there's a few medical students in the chat. If people want to sort of talk about their own experiences with how their training has been tailored to enable them to feel like they're accomplishing and setting goals for themselves that are realistic, that would be fantastic, because it links so closely to what we've been saying about vulnerability. And while people are doing that or putting other questions in the chat, Gramps, do you have any other thoughts on that?
I think, in fact, it's a very brave question, because, in fact, often we don't ask those questions, we just follow the routine. And I think in today's life, I think questioning is terribly important. Never withhold a question. It may be important to put it in such a way that it's not challenging or upsetting to the recipient, but I think it's going to make such a difference that in fact these questions are presented.
I think that's such a good point, and I do want to raise the point that in a clinical environment, for those of you that are either just starting your clinical environment or about to start your clinical years in medical school, you would be really surprised at how enthusiastic and devoted doctors are for teaching. I have spent whole afternoons with one clinician who's taught me through the entirety of a specialty as best that they could. And that doesn't happen with everyone, but all you need to do is ask. I've said to someone, look, I've spent the morning on the ward round with you. I have not understood a word you've said. I don't understand what's going on in the clinical picture here, and I can't correlate it to my learning. And they sat me down and they went through so much information, because part of what they're paid for is teaching. It goes into their portfolio, especially junior doctors and registrars. So if you don't ask, that won't happen. But if you say to someone, look, I need 30 minutes on this, I need you to tell me your knowledge on this, those are things I've also remembered the most for exams. So just following on from what Gramps has said, that's so important when you're in the clinical environment. Just ask. People will help you where they can, and if they can't, they'll give you a time where they can. And that's where I've learned some of the most information that I've found. Yeah, so that's a really excellent question, Emily, and really valid one too. I'm really pleased you raised that. Has anyone got any other questions? Feel free to put it in the chat. I know we're slightly approaching the end of time, so if anyone has any quick questions, I'd be more than happy to chat about them.
We've got 4 minutes left for today's session, but please do feel free to come into the chat or the Q&A. Leo, Emily has said thank you for answering. So interesting and helpful. Or you can, if you'd like to come on the mic, you can raise your hand and you can come and speak live, completely whatever's most comfortable for you. Well, people may be typing their questions. In the chat, I've just popped my email in case anyone would like to get in touch about this webinar or the work that Doctors in Distress does. Or if you have any further questions for Michael and Leo, you can always email me them and I can pass them on and we'll get an answer to you. And I've also popped in the link to our Eventbrite. If you give us a follow over there, you'll be notified whenever we launch a new program or a webinar like this one. So I've just popped them in the chat now if anyone would like those.
Wonderful. And even if people don't have questions, if people have comments on how the session went, if people feel annoyed, if people feel relieved, I'm sure it's sort of, because these are topics that don't necessarily come into the day-to-day conversations that medical students have, I'm sure they've brought up a lot of different feelings. So it'd be great just to hear people's thoughts on how they're feeling, just having heard from what myself and Gramps has said.
We have just had a comment in the chat from PB who has said, I have had similar issues as a mature first year medical student with newly diagnosed ADHD. Definitely have struggled with the rigid learning methods.
Yeah, it's really, really like synonymous with what Emily is saying as well, and what we've been discussing about this whole blanket policy for learning and education. And it's very two-dimensional, and it's very, very structured. And if we have a slightly more fluid way of learning, I mean, the only other advice I can say is that everyone learns differently, and everyone thinks the way that they learn is the best. I know people who basically should be paid by Anki to publicise their services, but I've never used that, and I've never found it very, very useful. I quite like gamifying my my revision tactics, so I sort of like draw like little comics and things to tie it all together. But everyone does things in totally different ways, and as long as you are retaining information and thinking about processes on a whole, sort of as a bigger picture, then you're learning in a fantastic way. And just remember as well, medical school is training you to be a safe and competent clinician who is an excellent communicator. We live in a digital age where information is so easily accessible, and you will always be able to draw on other people's knowledge and on the wealth of information that you've either learned or can access on the internet. So if you can understand the bigger picture and understand how to communicate information to a patient in a safe way, that in my book is more important than just being able to recall information. For exams, it's a slightly different picture. Exams are also very two-dimensional. You learn the content and you recall it, and that's a totally different story. But in terms of becoming a safe and well-rounded doctor, I think that speaks much more volumes than just learning and swallowing the textbook. Just got another comment as well. Honestly, one of the most eye-opening and reassuring conversations I had was with the doctor whose career I really admired, who opened up about mental health struggles, which I really resonated with. The stigma around this is harmful, whereas being open about it can help so much. Totally agree. And you know, medical students don't even have these conversations with their peers, let alone with doctors who they're sort of viewed of as being superior and untouchable and invulnerable. And those conversations, like you've mentioned, are so important and can be eye-opening. They can be really, really resonating and really special. So do open up. I've had poor experiences with a couple of doctors, but I've also had really special experiences with doctors who are introspective themselves and are able to draw on their wealth of experience and knowledge with themselves and peers as well. So the more you talk, the more you know. And it's so important just to voice things that feel overwhelming to your peers, because I guarantee you someone will resonate with it.
Thank you so much. So it is 5:30, so we have come to the end of today's session. But as I said, if anyone has any more comments or further questions, please do feel free to email me in the, my email's in the chat, and I will pass them on to Leo and Michael. But I would just like to say a huge thank you to everyone today for attending. We hope you found this session really useful, and a huge thank you to Michael and Leo for coming on to lead today's discussion. We will export this recording, and this will be sent to you via Eventbrite in the next week or so, so do keep an eye out for that. And as I said, if you would like anything, please don't hesitate to get in contact and give me an email. Please do follow our Eventbrite, and thank you again. I hope you have a wonderful rest of the day. Thanks, everyone. Thank you, Michael. Thank you, Leo.
This was really, really wonderful to speak on. So thank you for organising as well.
Bye-bye now.
Thanks.